All right, let's jump right in. In this explainer, we're going to close that gap between what you're reading in your A&P textbook and what you'll actually be doing on the floor as a pediatric nurse. We're covering the absolute essentials of the pediatric nervous system to help you feel confident and ready for anything.
So, here's our game plan. We'll kick things off with the basic A&P, the foundation. Then we're going to get our hands dirty with the pediatric neuro assessment. After that, we'll see how those skills apply in a spotlight on neural tube defects and then on cranial defects. And finally, we'll pull it all together and talk about your huge role in all of this. Let's do it.
Okay, first things first. Before you can spot what's wrong, you have to know what right looks like, right? So we've got to start with a super quick but super important review of the pediatric nervous system.
Think of it this way. It's all got two main parts. You've got your central nervous system, the CNS. That's the command center, the brain and the spinal cord. And then you have the peripheral nervous system, or PNS, which is basically all the wiring that connects that command center to the rest of the body. And that PNS splits again into the somatic system for stuff you choose to do, like kicking a ball, and the autonomic system for all the stuff your body just does, like breathing and your heart beating. Now, this is something you absolutely have to get. Those primitive reflexes, they aren't just cute baby tricks. They're like little diagnostic windows into the baby's brain. If a reflex that should be there isn't, that's a huge red flag for a CNS problem. But just as important, if a reflex sticks around way too long, past about a year, that could point to a problem in the frontal lobe. This is one of your very first clues that something's not quite right.
Okay, so now we take that textbook knowledge and bring it right to the bedside. We're turning that A&P into a practical, hands-on assessment. This is all about what you need to be asking and what you need to be looking for.
Your assessment doesn't start with a stethoscope. It starts with a conversation. You're trying to piece together the whole story. You're going to ask things like, how was the birth? Was it traumatic? Was the baby premature? You have to know if they're hitting their developmental milestones. Are there any behavioral issues that the parents are worried about? Even socioeconomic status matters. It can impact access to care. This history is the foundation of your whole workup.
All right, now for the hands-on part. You're going to measure that head circumference, or OFC. Is it growing too fast or not fast enough? You're going to check muscle tone. Is the baby really stiff, or are they kind of floppy, like a little rag doll? You're looking for tiny clues on the skin too, like a little dimple at the base of the spine, which could hint at something deeper. You're systematically going through everything, from checking cranial nerves to motor skills.
Okay, this is where it all comes together. We're going to apply those assessment skills and zoom in on a really common and really critical group of congenital problems, neural tube defects. This is where your sharp eye and quick thinking can change everything.
So what exactly are neural tube defects? Well, they're problems with how the brain and spinal cord form, and they happen super early in pregnancy. They're very, very strongly linked to not having enough folic acid. And here's the key part. The neural tube closes up at about 1 month. That's often before a woman even realizes she's pregnant. It's why folic acid is so critical for any woman who might become pregnant.
So let's break down the main types of spina bifida you'll see. Myelomeningocele is the most severe. You can see the spinal cord and nerves are actually exposed in that external sac, which causes paralysis. Then there's meningocele, where you have a sac, but the spinal cord itself isn't in it, so the issues are often less severe. And then you have spina bifida occulta. It's called hidden for a reason. The only sign might be that little sacral dimple or tuft of hair we just talked about in the assessment.
Okay, picture this. A baby is born with myelomeningocele. The clock is ticking. What do? This is your action plan. Number 1, protect that defect. Immediately cover it with a sterile dressing soaked in warm saline. We can't let it dry out. Number 2, put the baby on their stomach, prone, to keep any pressure off that sac. Then, get a baseline head measurement, start IV antibiotics to prevent infection, and get neurosurgery on the phone. These are your 5 critical, non-negotiable first moves.
And then there's anencephaly, another neural tube defect. It's a truly devastating condition where large parts of the brain and skull don't develop. But this is Jackson. He lived to be 5 years old, completely defying expectations. His story's it's a powerful reminder that our job as nurses isn't always about finding a cure. Sometimes it's about providing comfort, dignity, and supportive palliative care for the patient and their family.
All right, so we've talked about the spine. Now let's move up to the cranium, to the skull itself. We're going to look at some defects where the main challenge is managing fluid and pressure inside the brain. It's all about plumbing and pressure.
This is a classic picture of hydrocephalus, which is just too much cerebral spinal fluid building up in the brain. But I want you to look really closely at this child's eyes. See how they're pushed downward? That's called sunsetting eyes, and it is a major, can't-miss sign of dangerously high pressure inside the skull.
So, how do we fix this pressure problem? Well, here's the solution. The ventriculoperitoneal shunt, or VP shunt. It's basically a clever little plumbing system. It's a catheter that drains that extra fluid out of the brain's ventricles, tunnels it right under the skin, and empties it into the abdomen, where the body can just absorb it. Simple, but brilliant.
Okay, the shunt is in. Now, your job is huge. You are constantly on the lookout for signs that the shunt isn't working. Things like vomiting, a bad headache, or the child just being really irritable. You're watching for any sign of infection. And maybe most importantly, you have to educate the caregivers. You have to turn them into experts because they're the ones who will need to spot a problem when the child goes home.
And one more quick one you should know about is craniosynostosis. This is when the plates of the skull fuse together too early. You'll spot it as an abnormal head shape. The big problem here is that the brain literally runs out of room to grow, so it requires surgery to open up those sutures and give the brain space to develop properly.
Okay, let's wrap this up and bring it all home. We've covered the science, the assessment, and some really complex conditions. Now, let's talk about what I think is the most important part: your impact, your role in managing these lifelong conditions.
And the first thing to remember is this: you are not an island. Taking care of these kids is a total team sport. You've got physical therapy, occupational therapy, speech, social work, neurology. Everybody has a critical part to play. And guess who's often the hub of that wheel? The person connecting all those pieces for the family? That's you. That's the nurse.
And that really brings us to the most important question of all. Your job is so much more than tasks and charting. These families are on a journey that's going to last a lifetime. So I want you to think about this. Beyond all the clinical stuff, how can you empower them? How can you give them the knowledge and the confidence they need to take care of their child? Because that is where you make the biggest difference.